Thank you. Good afternoon, everybody. I think I can keep this very, very short because Virginia covered most of the important. Is it on? Sorry. Virginia, as I said, covered most of the important issues already. So I'll make it rather short, and then we can hopefully go a bit more into the debate afterwards. First of all, however, I have to give you an introduction to my company because I'm constantly actually confused with another company. We are the oldest company, a pharmaceutical company in the world, since 1668, founded in Germany. And Merck is not the same as the other Merck, because there's also an American Merck who used to be our American subsidiary, which was nationalized in 1917 during the First World War, and ever since then is a separate company, which is why you have MSD, Merck Sharp and Dohme in Europe, and Merck, us, the German Merck. So sometimes we are confused, and I always need to make this as a entry remark. So, tendering in healthcare. Tendering has actually been widely used in the healthcare sector, especially in the hospital sector, for many products. As you see here, 25%, in some countries, 25% of all the products actually that are used in a hospital go through tenders. For medication, most of those products actually have been generic drugs, i.e. I'm going to use one of our other company product, aspirin. If you take an aspirin from the originator Bayer, or you take it from any generic product, it always will stay an aspirin. So you can probably put it in a tender and see who gets you the cheapest product. Recently, what we see is actually also that they procurement authorities, hospital, finance departments will start putting together different kind of products that should, in theory, treat the same disease into one tender, and then also only look at the price and say, well, we take the cheapest, and thereby they do not fully take into account the differences between different drugs and medicines, which is the next slide. If tenders are always used, or have been always used already in hospitals and in the healthcare sector, why even bother? Why is this suddenly an issue? Why do we say, please, dear Parliament, dear Commission, you need to look out a bit and see that there's specific and different rules for biotech drugs especially? And I tried to actually show you this in this slide. If you tender today a rubber glove in a hospital, it is pretty much easily to be described. You need, I don't know, I guess, a rubber glove in 5 different sizes for the different hand sizes, and it should be protecting against any kind of infections. Or you need a hospital gown that also you need in 5 sizes, and it should be washable at 60 degrees, I guess, and should hold or resist 500 wash cycles. This is stuff you can actually identify, but what you see at the other side is a DNA. And when we talk about biological medicines, we're talking about products that look different. And that's a slide from our trade association, Europa Bio, where we try to explain a bit the difference. What is a biological, what we are talking about, or what I'm talking about today, and a chemical drug? What you see, the small little molecule that you see over there on the right side is, again, aspirin. As you see, it's very simple. It can be chemically manufactured in a big manufacturing site. And what you see on the left side is EPO from another big biopharmaceutical company. That's a drug you will get if you have a kidney dysfunction. And as you see, it's a very complicated molecule, and the real big difference is that it's not chemically modified, but it's actually run or produced by living cells. So what the companies do, they change the living cells to produce a human-like hormone product, whatever, protein, and therefore any slight changes already in the production line will cause a different molecule. It might just be that this little wing on the right side might look different, which might cause that in your body it causes a different reaction. Therefore, in the European law, what we have is that you can produce generics. I think everybody is normally familiar with that term. In chemical drugs, you can make generics of, whereas for biotech drugs, you can only make biosimilars, i.e. meaning they're only similar but not identical, and therefore not interchangeable. So, having shortly explained the difference between biotech drugs and chemical drugs, the question is again, can tenders work for all medicines? And clearly, coming from a biopharmaceutical company, we would say for non-identical drugs, no. We would prefer not to go into a tender, but rather in, as Virginia said, a negotiated procedure where we discuss with the medical staff and the procurement staff of a hospital on how to actually procure those drugs. Also, I put this down here, is that a tender very often also overlooks the whole bigger picture of a drug, because if you only look at the price and say it should treat disease X, you forget all the new innovation that come with drugs. It's devices, it's less treatments, i.e. only 1 injection per week instead of 3 injections per day. Those are differences that tender very often will not look at if it's run by a financial department. Virginia actually, I think, covered this already, that the incentive is gone if you tender. If you pool together an old drug, i.e. a generic drug, against a new modern biotech drug, which might both go for against the same disease, but again, the generic drug you have to take in the morning, at lunchtime, in the evening, and the injection you get once a week, and you're happy to go. So all those differences are often not actually taken care in a tender, and therefore we lose the advantage of those drugs, or they're not assessed. And yeah, tenders rarely look beyond the price. I think all this has been covered before. So what we say is, if they can't be avoided, because we see it now in the hospital sector that actually different drugs are pulled together into one tender. We have seen cases in some countries where tenders even go so far that they will start promoting off-label use. That i.e. you have 2 drugs that work for the disease A, and the second drug also works for disease B, but then the tendering authority says, well, if it both work for disease A, then we also use it for disease B, even though only one of those drugs is approved by the EMA for the disease B. So there's where we say, please, you need to take into account that the biological drugs are very different, and you need to listen to the medical science. So I think that's that in short. So, and then coming to the Public Procurement Directive, which is, I think, we were here for. Unfortunately, Mr. Tarabella couldn't make it today. We were looking forward to discuss with the rapporteur in the Parliament a bit more in detail what we think as the biopharmaceutical industry, what should be done. And we, as Virginia already said, we really think that the negotiated procedure should be the way forward for non-identical drugs. You can only tender drugs or medications that are identical, bioequivalent, multi-sourced, and off-patent, i.e. mainly the generics, or in the general healthcare sector, then obviously also the hospital gowns or the rubber gloves, because those you can really identify. As I said, negotiate procedure, biological drugs, that's the way to go forward. And please do not forget that when we talk, this is all very business-driven. We are actually here to support patients and help patients to get better. So very often, if you only talk about figures and what's the cheaper drug, we sometimes keep on forgetting that we're in this for the patients, and one day all of us will be patients. In detail, I don't know if anyone is here from the Parliament right now. That was the big ask to the Parliament, please. To make the mandatory transposition of all procedures, i.e. Article 23 to 30, which I think, as we said, that the negotiated procedures in there, different procedures. We feel that once we are able to actually engage with the contracting authorities in a dialogue, that we will come to a very good procedure that will guarantee that patients and doctors have a full medicines cabinet. Then the meat and life cycle assessment, i.e. life cycle assessment for us also means that devices go into this assessment, adherence. Many companies are looking into how do we improve patient adherence, i.e. meaning how do we get patients to actually take the drug, because there's always a difference between a doctor prescribing a drug and the patient actually willingly taking that drug and thereby getting a better treatment outcome. Those kind of things should go into the assessment. And then there's the other call for the Parliament and the Commission, and please, as it's biotech drugs are a complex product, and that we understand this is a directive that actually covers all kind of public procurement. We will call for some implementation guidelines for biopharmaceuticals so that we can better engage with the contracting authorities. Then the next point, the division into lots framework agreement, that goes also back to what Virginia already said, that once a patient is on one biotech drug, and that can also be, even though I come from an originator company, this can be a biosimilar. Once you start on a biosimilar, i.e. a biological generic, once you're on this, it is, unless you have a scientific reason to change, the patient should stay on that drug. Therefore, we should be able to provide a full medicines cabinet. The doctor should be able to have the choice what to prescribe. And once a patient is on a drug, he should stay on that and not... So in some hospitals, they tender every 3 months. So you need to think that in theory, you would be changed every 3 months onto a new drug, which is not very good for the patient. And then Virginia said that as well. Sound procedure, that's those big points are actually the clusters that the Parliament identified, and confidentiality is vital. And the last slide from my colleagues in the company, they just try to see what actually is the difference between a good tender design and a bad tender design, that there's benefits in it for all of us, for the payers, for the patients, and the manufacturers, i.e. especially for patients and physicians, they can get the best treatment, the right treatment for the right patient. I think that's what it is all about for us. Okay? Thank you very much.